Welcome to the SAB's July webinar, The Role of Diagnostic and Therapeutic Bronchoscopy and Lung Transplantation, as part of the SAB's 2022 educational webinar series. Before we get started, a few housekeeping items to remind everyone. You all have joined in a listen-only mode. You may ask questions throughout the webinar by using the question feature located on your control panel. We will address all the questions at the end of the lecture. Dr. Danish Ahmad will be moderating tonight's talk. He is the chair of the Education and Program Committee here at the SAB. Dr. Danish Ahmad.
Hi, everyone. Thank you for joining us. And please join me in welcoming Dr. Frye. Dr. Laura Frye is a leader in the field of interventional pulmonology, specific dealing with lung transplantation. She completed her internal medicine residency, and prior to that, medical school at the University of Kansas. After that, she moved to Philadelphia, where she did her pulmonary critical care training at the University of Pennsylvania. She then moved on to Cleveland Clinic to complete her interventional pulmonology fellowship. Her clinical research is focused on benign airway disease, particularly on airway complications following lung transplantations, and her clinical time is split with roles in interventional pulmonology and contributing to the growth of the University of Utah lung transplant program. Once again, Dr. Laura Frye.
Thank you, and thanks everybody for joining. I'm going to talk tonight about both diagnostic and therapeutic bronchoscopy and lung transplant. As Danish mentions, I split my time between transplant and IP, so this is very much my passion. I'm hoping that everybody's going to learn something a little bit new this evening as I talk about some of the new techniques that we're using in the lung transplant. So I have no disclosures related to this talk. What we're going to talk about once again is we're going to talk about the role of bronchoscopy in just our usual routine post-transplant surveillance. We'll also review the ISHLT consensus statements related to transplant bronchoscopy, both diagnostic and therapeutic bronchoscopy. And then we'll discuss how we utilize bronchoscopy during episodes of respiratory decline, in particular how we manage airway complications, the approach to those complications, and the anticipated outcomes. Flexible bronchoscopy is used for a multitude of reasons in the lung transplant space. We do this for pulmonary toilet, especially early post-transplant, as these patients can have impaired mucociliary clearance and can have issues clearing secretions requiring bronchoscopy. It's also a vehicle for us to identify risk factors for chronic rejection, recognizing that the 50% outcome 6 years is really, if we look at graft function, that's related to chronic rejection, and we have some things that we can intervene on if we identify them early. Those are episodes of acute severe rejection, persistent mild acute rejection, so those patients that we biopsy and they have persistent A1 or even A2 rejection, patients who have infections, and then potentially we can actually use bronchoscopy to find signs of aspiration or GERD. It's a vehicle to identify airway abnormalities. And each time we do a bronchoscopy, it could be a simple airway inspection to inspect airway healing, or we could be doing a bronchoalveolar lavage or a bronchial wash or transbronchial biopsies. So every transplant program has a slightly different schedule if they are in fact doing routine surveillance. And keep in mind that not all programs do surveillance routinely. It's probably only about 2/3 of programs that do routine surveillance bronchoscopies. The programs that do those typically will do an index hospitalization bronchoscopy at about 1 to 2 weeks, and then oftentimes a 4-week or a 6-week bronchoscopy that may be with or without biopsies. The schedule then after is anywhere from every 2 to 3 months up until the 12-month mark. And there are a handful of programs that actually take that all the way out to 2 years. Not very many programs go beyond the 2-year mark when we talk about doing surveillance bronchoscopies. Clinically indicated bronchoscopies we're going to do anytime there's an abnormality in the patient's imaging. If they've got worsening shortness of breath, a drop in their spirometry, if a patient has a new unilateral wheeze, that is somebody that I'm definitely taking for an airway inspection. Or if they're newly hypoxemic, I'm ruling out rejection, infection, and airway issues. We know that infectious complications are common in our patients, especially early post-transplant. So 16% of our patients will have bacterial pneumonia requiring treatment in the first month post-transplant. Our patients are also prone to viruses and fungal infections. So 5% of our patients will have true CMV infection with incredibly high relapse rates, up to 60%. Aspergillus is also commonly seen in our patients, colonization rates in up to 50% of our patients, true infections in probably about 5%. And this can have a devastating consequence as patients can have progressive disease with invasive pneumonias and the potential to erode into adjacent pulmonary vasculature. Now, recognizing that every program has a different surveillance schedule, the International Society for Heart and Lung Transplant has at least tried to create a consensus statement for how we perform our lavages when we do them. And this working group was comprised of myself and a lot of other individuals that you see here, many of us who are doing a lot of bronchoscopy in the transplant space or microbiome work in the transplant space, which was what my basic science background was. And what we agreed upon was that when we do a BAL in the transplant surveillance bronchoscopy, that would be done with a sequential installation of 250 cc aliquots. And since this is for surveillance alone, that's going to be in the areas that give us the highest yield. So in the lingula or in the right middle lobe. There's no dwell time with these BALs. So you instill that 50 cc's and then immediately aspirate. The recommendation is that you attempt to avoid suction prior to your BAL so that your sample is not contaminated. So avoiding suctioning oral secretions or airway secretions, but really just driving in that bronchoscope, wedging in the airway, and performing your BAL. These samples also, we would like them to be as clean as possible and not have a lot of bronchial cells, so try to avoid airway collapse. And when I do these, I typically use manual suction, not wall suction, so that I can really have that best sample possible. And then in patients that you're worried they might have sinus colonization, specifically in the CF space, we would not do a nasal route for those bronchoscopies. The studies that are recommended in this consensus statement, you can see here, every patient should get a cell count with a differential, basic microbiology for bacteria, fungi, mycobacteria, and then respiratory viruses and cytology. Depending on the individual patient, you may also add CMV, Nocardia, pneumocystis, or galactomannan. And then something that's newer are these options for rapid microbial detection. So one of those is the BioFire Pneumonia Plus panel. And if we compare that to sort of our conventional diagnostics of microscopy and quantitative culture, our viral testing, our PCRs, this actually gives us an increased chance to really narrow those antibiotics quickly. But unfortunately, this isn't perfect for transplant recipients because it's missing some relevant bacteria. And importantly, it's missing fungal infections. It's also missing some viruses like rhinovirus. But we're talking about all of our donors who get bronchoscopies done for inspection of the airway and understanding of secretions. This actually, in the donor space, may allow us to more rapidly narrow our antibiotics rather than waiting for those donor cultures in the early post-op period where we're having patients on broad spectrum antibiotics for 3 to 5 days until we get those final cultures back. Again, as I mentioned, it does miss some important aspects of the post-transplant patient microbiome. So we aren't going to see any fungal infections. So Aspergillus, Mucor, the fungus that we really worry about in transplant, not going to be captured here. You can also see that we're missing some viruses. So again, for the most part, great on the donor side, helpful on the recipient side. Just know that you're probably going to use this to add to your current practice, not to take away anything that you're currently doing. And then in addition to our BALs, we are also taking biopsies. We're taking biopsies to look for 2 different types of rejection. So we're looking for acute cellular rejection. We're also looking for antibody-mediated rejection. And acute cellular rejection, if you look at the ISHLT outcomes, we know that about 1/3 of our patients will have an episode of treated rejection in the first year after transplant. And those episodes of rejection are one of the major risk factors for our patient getting chronic rejection. And that's dependent on the severity of the episode. So it's graded in severity from A0 being nothing to A4 being severe, or the number of episodes. So if you have a transplant patient who every time you bronch them is having episodes of A1 rejection, that's someone who needs augmented immunosuppression. But keep in mind that when we augment immunosuppression, we are also increasing their risk of infection. So this is always a little bit of a balancing act in the transplant space. And again, our acute cellular rejection is diagnosed based on biopsies, and it's based on that A grade that you will see in your reports. And this is actually based on, once again, ISHLT has a standardized nomenclature for the diagnosis of rejection. And it's as you see in this table here, we talk about A, acute cellular rejection, which is our A grade. You also might see airway inflammation commented on. Very, very rarely will you actually see the C, and those are the changes of chronic airway rejection. And then even more rare is that D grade. And when a pathologist is looking at it, this is really what they're looking for, is this pathologic grading of acute cellular rejection. So A0, not surprisingly, is normal. A4, which is the most severe cellular rejection, they're going to have diffuse perivascular, interstitial, and airspace infiltrates with mononuclear cells, and then pneumocyte damage. So it's a spectrum. Obviously, this is not a science. So pathologists who are grading these are typically the same pathologist looking these routinely. The diagnostic criteria obviously is something that is agreed upon, but this is not anything that's guided by strong science. So when we talk about what a diagnostic bronchoscopy is for rejection, we're looking for 5 pieces of well-expanded alveolated lung tissue. When we take our biopsies, you could gently agitate those in saline to inflate that tissue. Doing forceps biopsies can lead to crush artifact, and that's related to the technique of the biopsy, and then also potentially how we handle our samples in the lab. So there's been a question of whether we should be transitioning from forceps biopsies to cryobiopsies. I'll be honest, as a transplant pulmonologist who does cryobiopsies, I'm not 100% certain that I'm sold, but we'll see how this data evolves over time. And again, you're seeing, obviously, when we do cryobiopsies, larger pieces of tissue, but for most cellular rejection, I don't know that that larger size and that increased architecture drastically changes the diagnostic yield of our bronchoscopies. And if you look at the complication rate, you'll see in the study that I referred to on the right, that the overall complication rate in that study was 9%. And if you look at the bleeding rate of cryobiopsy was 8%. And with forceps biopsies, only 1%. The study on the left does show that, in fact, we get larger pieces, something we already know. There's also less crush artifact and less bleeding artifact just because of the technique that we use to do our cryobiopsies. But if it's worth the trade-off of the increased bleeding rate remains unclear. That also would mean that each of our surveillance bronchoscopies is being done under general anesthesia, whereas most programs are doing these procedures with moderate sedation. So it's a large practice shift as well if we talk about changing this, especially for high volume centers. This is one space where it may potentially have a role, and that is in the detection of antibody-mediated rejection. This is divided into 2 realms. So we have clinical, which has measurable allograft dysfunction, and then subclinical, where we might have a donor-specific antibody, but we have normal allograft function. There's no standardized treatment for this. So we know that we want to deplete circulating antibodies, and we want to suppress our B cells to not produce more antibodies. And you can see there's a whole gamut of treatment options, and all of these have potential complications. So when we talk about AMR, we want to truly understand, what does the tissue look like? What does the donor-specific antibody look like? And what's the patient's graft function? So again, there's a consensus report from the ISHLT that helps guide us to know if we've got probable or not likely AMR. So definite antibody-mediated rejection. Patient has allograft dysfunction. We've ruled out other causes. We have tissue and lung histology, as well as a C4D, which is your complement deposition that supports this being AMR, in addition to a positive donor-specific antibody. And this is what we would be looking at if we're talking about that complement deposition. So this is C4D staining that you see in that top right corner. And then the patient would get treatment. You would see that C4D staining decrease. And then you've got the normal appearing lung on that last slide in D. So as I mentioned, not every center does surveillance because it's unclear if doing a surveillance bronchoscopy versus just doing clinically indicated bronchs based on symptoms, PFTs, if it really changes your long-term outcomes. So only 69% of centers routinely perform surveillance. And the schedules, as I mentioned, vary. So every program chooses their schedule, early bronchs, late bronchs, and when they bring those patients in. Vince Valentine's group actually looked at routine surveillance versus clinically indicated bronchoscopy. And having a low threshold for clinically indicated bronchoscopy, they showed that there was no difference in their diagnosis of acute rejection, infection, or importantly, in their BOS-free survival. However, this is sort of balanced against this paper by McWilliams, where they showed that they detected a lot of asymptomatic infection. So they might have caught patients before they deteriorated. And they also saw that in 18% of their patients where they had a surveillance bronchoscopy, they actually detected A2 or greater grades of acute cellular rejection. So I think as somebody who does a lot of these surveillance bronchoscopies, I don't see myself significantly changing until we have better non-invasive ways of tracking patients over time. And we're getting there. One of those non-invasive tests, there's actually a couple on the market, but what they do is they look at donor-derived cell-free DNA. And so this will differentiate donor DNA from patient DNA using differences in single nucleotide polymorphisms. And we know that the percentage of donor-derived cell-free DNA when it is greater than 1% is an indicator of active rejection. And this can be monitored longitudinally over time. So let's say we're making changes in immunosuppression. We're at a point where our program would typically reduce our anti-metabolite, whether that be CellCept. And so let's say we normally would drop from 1,000 milligrams to 500 milligrams. We can now use this as a non-invasive way of tracking whether or not our patient is having any low-grade rejection in response to that change. Or as we commonly see in our transplant population, the patient's neutropenic and we're adjusting medications, our antivirals, our immunosuppressants, we can monitor this as well. It's important to keep in mind that if we are doing these types of tests, that these are tests that are done before the bronchoscopy. So you don't want to do a surveillance bronchoscopy and then immediately after the procedure, draw this lab, because we know that that's going to falsely elevate your donor-derived cell-free DNA. And then this was the results from the prospective valid study. So this was done at OSU. They did 195 samples and 103 patients, and they identified 35 acute rejection cases. So positive predictive value, 52%, but the negative predictive value was 97%. If we look at their data a little bit closer, we can actually see that when we use the threshold of 1%, this is helpful for us diagnosing ACR, AMR, and even one of the highest values I've seen to date has been in one of my patients who had an active infection. So you can look at that range to figure out kind of what's revving up your patient's immune system and potentially causing this to be elevated. And then let's say we've done a bronchoscopy. Our patient had new shortness of breath. We did the bronchoscopy. BAL is normal. Biopsies are normal. The other thing that we're going to be looking for is an airway complication. So when I suspect an airway complication is shortness of breath, increased wheezing, again, that unilateral wheeze is really going to point me towards there's something wrong with one side in particular. The patient has chest tightness. They have a cough and they've got sputum production, but now they can't expectorate sputum. There might potentially be some narrowing of the airway, whether that be a stenosis or be malacia. If a patient has recurring post-obstructive pneumonia, it is worthwhile to take a look at their airway. If they've got a change in their spirometry, specifically if they've got changes in their spiro loops that are suggestive of an obstruction, or obviously if somebody's done a surveillance bronchs, one of my partners shows me a picture, that is the best way for me to know that there's something going on with the airway. And then the last thing is abnormal imaging. So there are signs that we might see on chest x-ray or signs on CTs. So if we're doing a CT of the chest for evaluation of an airway issue, ideally I'm going to be doing that with inspiratory and expiratory films because I'm trying to get an idea of what the airway looks like. Is there fixed or is there dynamic narrowing of the airway? And then on chest x-rays, you might see evidence of luminal compromise. So the x-ray that you see on the right is actually a patient who has some vanishing BI syndrome developing. And so when you have vanishing bronchus intermedius syndrome, you could have collapse of your right middle lobe, your right lower lobe, or potentially you could lose your right middle and lower lobes with both lobes collapsing. So in an ideal world, every patient I see for an airway complication would have spirometry before I do a procedure, after I do a procedure so that I know whether or not it worked. We would have imaging, chest x-ray, at least CT scan, even better. And then oftentimes these patients will undergo a surveillance bronchoscopy with photos taken. And that's again to rule out rejection or infection, other things that we might be intervening on. And then those photos are helpful for me as the proceduralist to get an idea of what I potentially need for the upcoming procedure. Is this something where I obviously am going to have to put a stent in? Is this something where I might be okay with just a dilation? It's really going to help me with that basic procedure planning if I've got a couple of photos. Obviously, I can't measure a stent from a photo, but I can at least get an idea of what I potentially need to stent so I can start to plan. And when we think about airway complications, we can really divide these into what we would expect to see early post-transplant and what we'd expect to see late. Our early airway complications are really related to ischemia and ischemia reperfusion injury. And so you might just see a lot of mucosal sloughing. You could see anastomotic ulceration. And then fortunately, in very rare cases, does this happen, you could see an airway dehiscence, and that could be with or without a fistula. Later on, as the airway heals, we can see signs of airway obstruction, and this could be related to granulation tissue, especially if there's loose sutures at the anastomosis. Sometimes that will cause a little irritation and you'll get granulation tissue. You could get fibrosis and a band-like stenosis, or you could get dynamic airway collapse. And these can happen not only at the anastomosis, but can happen into the more distal airways. If you look at the data, and if you look at what's been published, one of the challenges of having this as sort of my area of interest has been, it is very challenging to do research in this area because up until a few years ago, there wasn't really a definition of what an airway complication was. So if you were a surgeon, what would you say a complication is? Is a complication a significant dehiscence that you have to take back to the OR for a repair? Because if that's the case, your complication rate is very, very low, the 1.6% that you see at the top. Or do you have a more sensitive definition and say that it's anytime I see changes of necrosis, which you can see on that early index hospitalization bronch at day 10 to 14, because if that's your definition, that's going to lead to that 64% that you see in that bottom paper. And then you can see that spectrum of rates in between. So really, if you think about an airway complication that requires intervention, we're probably looking at a rate that's somewhere in the teens. So recognizing this, International Society of Heart-Lung Transplant actually created a consensus statement on airway complications after a lung transplant. They made definitions, they made a grading system, and they briefly discussed therapeutics. This looks at all of the types of airway complications I'm going to talk about. So it looks at necrosis, it looks at dehiscence, it looks at stenosis, it looks at malacia. And that grading system is defined by how far those changes extend from the anastomosis. Now, this grading system was published about 5 years ago. And many of you may have received a survey from me that looked at whether or not your program is currently using this grading system. And unfortunately, even though this grading system is in place, we haven't had the best about our uptake of this grading system. Fewer than half of individuals who are doing routine bronchoscopies on transplant patients are actually using this in their reports. So again, doing research in this area is going to be challenging because we haven't adopted the tools that we need to really execute meaningful research. And why do we care about complications? Do they really matter? And I would say, as a transplant pulmonologist, definitely. They are associated with morbidity, they're associated with mortality. If a patient has a transplant-related airway complication, if I have to intervene once, I know I'm probably going to have to go back a second time. And based on this paper by Santa Cruz, you can see that about 35% of the time, you do something once, you're going to have something that happens that's going to require a second treatment. If you have to do something twice, even more likely you're going to have to do something for a third time. So this can affect patients' quality of life. These patients underwent a transplant so they could get off of some of these therapies, so they could get off of breathing treatments, not have to have these types of procedures done. And obviously now they're coming back for frequent bronchoscopies. There's also complications of the therapies. We all know that stents are not a benign intervention. And then in our cases of very severe complications, so those cases of airway dehiscence, those cases of fistula formation, patients can actually die related to their airway complication, especially if something erodes into a nearby vessel. And we've come a long way with transplant, but really it's kind of a setup for, unfortunately, these types of issues to happen. We devascularize that anastomosis. So it is relying on retrograde low pressure flow from the pulmonary arterial circulation via collaterals for weeks after transplant. It's also not a stress-free anastomosis. These patients are on positive pressure ventilation in the OR and often for periods of time after the transplant. And it's impossible for us to perfectly match the size. So I can look at measurements when I get donor call and try to match my recipient and my donor lung volume sizes, but that doesn't mean that the airway is going to be a perfect match. It's also not a sterile field. So my surgeons are in the OR, they are suturing in a field with colonizing pathogens, especially patients with cystic fibrosis. We may be explanting the lungs, but we are not removing the trachea and the central airways. And then there's always the risk of infection of the site. So that area that's getting low flow is a setup for fungal infections, particularly Aspergillus. And that's why a lot of programs will actually use inhaled antifungal medicines in the early post-op period until that blood flow is more normal. And then there are a lot of papers that have tried to identify things that we can potentially modify. I can't modify the duration of donor mechanical ventilation. I can't really change my patient or my recipient height. I can change my surgical technique, and we have. So telescoping anastomosis, that technique is no longer used routinely. Not really changing the lung disease. Our patients are sick. There's a high probability that patients are going to, with increasing frequency, be hospitalized at the time of transplant. I can try to more aggressively treat infections. So identifying things like Aspergillus and actinomyces and putting them on appropriate treatment, treating Pseudomonas. Again, the episodes of rejection are probably related to a vasculopathy. And so that's potentially why that early acute rejection in multiple papers comes up as a risk factor for airway complications. And then the telescoping anastomosis, if you think about that in terms of surgical technique, if you telescope whichever airway is smaller inside of the larger airway, so that recipient donor mismatch, unfortunately, that is naturally creating an area of stenosis. So not surprisingly, that's associated with more frequent airway complications. And then again, we're relying on low pressure flow for several weeks. There are a handful of centers that will routinely do bronchial arterial anastomoses at the time of transplant in young patients. So if we look at those centers, they're going to have potentially a lower rate of complications. And that is sort of shown here as you look at patients who undergo a heart-lung versus a lung-only transplant. So we talk about lung transplant, we're talking about a bronchial anastomosis. When we talk about a heart-lung transplant, those are done in block, and so those patients will get a tracheal anastomosis. So that tracheal anastomosis has an airway complication rate of about 2.9%, versus, again, I talked about the challenge of saying what that rate truly is in lung only, but it's probably somewhere in the teens. And again, this is all related to tissue perfusion. And then as we are doing more transplants, one of the things that's come to mind is how does our donor type affect these airway complications? So if we look at patients who are deceased after cardiac death versus brain dead donors, vast majority of lung donors will be brain dead donors, but more centers seeing, number one, that we need a larger donor pool to meet the need for transplant, especially as we're seeing more COVID transplants, are starting to look at DCD donors. And so this was a systematic review that looked at studies from the early 2000s to around, I believe, 2011. There were 9 studies that were included in the analysis with about 3,000 patients, most of whom were brain dead donors. 403 were DCD donors. They saw that 1-year survival and primary graft dysfunction were similar in the 2 groups. What stood out was the frequency of airway complications. So DCD donors had an odds ratio of 2 of having airway complications. So as we start doing more DCD donors, those of us who do bronchoscopies need to be prepared to be doing more potential airway interventions. The other thing that potentially is a consideration with DCD donors is a reduced 5-year survival. Again, limitations of the study, it's a systematic review, but just something, if your center is starting to explore DCD donors and you routinely do bronchoscopies on these patients, keep in mind that you might be getting more phone calls and be doing more interventions, usually for issues with ischemia and necrosis early on that have a potential to heal into a stenosis. And then, as I mentioned, surgical technique. So if I'm talking to a surgeon and they're asking me what I would like them to do, I want an end-to-end anastomosis. So I want that anastomosis as close to that secondary carina as possible and not have a lot of extra length of that donor bronchus because I want to get the best blood flow possible. Telescoping essentially just creates a stenosis. There have also been attempts to do buttressing with omental wraps and pericardial wraps, hoping that that was going to improve blood flow. That actually did not, and it also increased the stenosis with the frequent use of wraps. And this is what we see here. This is looking at airway complications based on surgical technique. So you can see that end-to-end versus telescoping is far superior. And then there have been efforts to publish algorithms about how we manage this. Obviously, every patient is different, but this is a paper by Sid Murthy from out of the Cleveland Clinic. And not surprisingly, if you have a dehiscence with a large fistula, recommendation is that your surgeon consider operative repair. If it's a dehiscence without a large fistula, we would proceed with an uncovered stent. And then if the patient has obstruction, really we're looking at, are they symptomatic versus asymptomatic? If they're asymptomatic, that's somebody we might just watch. If they're symptomatic, we need to start thinking about endoscopic intervention. So that's when it really falls into our space. And what are the options? There is an abundance of things that we can try. It really is going to depend on what your comfort is, what's in your wheelhouse, and what do you have available. So if we're talking about granulation tissue, you may be doing microdebrider, forceps debridement. Stenosis could be balloon dilation or scope dilation. You may need to use a cautery knife to open that airway. Very, very rarely are people using APC. I use a lot of cryotherapy with a cryoprobe. Steroids, some people do use. Obviously, these patients are already on a lot of systemic steroids, so how effective those are is unclear. Anti-proliferatives like mitomycin can be beneficial, not necessarily in preventing a restenosis, but at least delaying your time to next intervention. There are some papers that mention PDT, but that is very, very rare. And then we've got multiple options for different stents when stents are indicated. So stenosis is the most common complication. It's associated with necrosis, infection. It can also be how a dehiscence heals. It can be at the anastomosis. It can be more distal. Therapy is usually dilation, potentially with electrocautery or a stent. And this is actually a case that I took care of with a patient who had episodes of chronic aspiration. He had really poorly controlled reflux and had a BI stenosis. You can see in the left-hand photo, pretty much his airway was completely obstructed, able to make a cautery cut and then pass a balloon and dilate that. The right photo is how he healed after cautery cuts and dilation. Not perfect, but he was somebody who wasn't going to be compliant with airway clearance for a stent. And so this was sufficient for him to not have significant symptoms. And some people will argue whether or not the only airways we should be stenting are the airways in blue. So should we only stent central airways? Or is transplant the one space where we could potentially argue that we should be stenting lobar bronchi, especially early post-transplant, because sacrificing a middle lobe in a patient who I've just transplanted with a single lung transplant is going to be something that I'm probably going to fight you on. But again, lobar stenting versus just doing frequent balloon dilations, it's going to really depend on the frequency. If I have somebody I'm dilating every 4 weeks, I might choose that over doing a stent and dealing with the potential complications of a stent. And we have a lot of stents that we can choose from. So we've got the Ultraflex, the Aero Mini, and the bonus stent as our SIMs. We've got balloon expandable metal stents. These are what I often use for lobar stenting, like the iCast. We've got silicone stents, and then we've got some other stents that are on the market that we can also use as needed. The SIMs are cylindrical wire mesh of nitinol. They have a shaped memory. They're going to apply a constant radial force. They come both covered and uncovered. Sort of the teaching point in transplant is that the only time we should really be using an uncovered SIMS, because again, remember, black box warning for metal stents and benign disease, that uncovered stent is what we are using in cases of dehiscence to encourage the complication of a stent and hopefully get airway healing. We should be using our covered SIMs if we can't seat a silicone stent, and then obviously have a follow-up plan in place. Those covered stents, we've got the Ultraflex, which is covered with silicone, and the Aero and Aero Mini, that's covered with a polyurethane. Thought process with that is that that inner lumen is hydrophilic, so maybe we'll have a little bit less issues with plugging. These can be deployed either with direct visualization, flexible over the wire, or sort of an alongside the scope, sort of a piggyback technique. Again, indicated for dehiscence or inability to seat a silicone stent. They should not be your go-to for a stenosis unless you know that you can't seat a silicone stent or you'll lose too much airway with a silicone stent placed in that location. The advantage of the SIMs is that they're easy to put in and they're flexible. So if you've got an airway that has some funny angles just because of the surgical site, this is going to seat a little bit more smoothly than a silicone stent. You can also potentially still airway and drain if you're placing this across an orifice. So let's say we've got a right mainstem dehiscence and we're going to partially obstruct the right upper lobe to put a stent in place. You're still going to drain because you've got an uncovered stent. They also get a little bit less biofilm than silicone, but this is why they have the black box warning. They're difficult to remove, so they embed in the airway. They can also fracture. They're also expensive, and they can form granulation tissue. So this is what a dehiscence would look like on a CT scan. So you can see that little pinhole dehiscence. It's seen early post-op. If my patient has a persistent air leak or they've got a pneumothorax that's not placed on, explained by size mismatch, I'm going to bronch this person looking for a dehiscence. And this is unfortunately what it would look like. So that top photo is a large dehiscence. Unfortunately, I'm upside down in the airway. So think about turning your head and looking at the airway there. And you can see that there's a large defect. So this patient had an uncovered stent placed, as you see in the bottom left-hand photo, and then had good healing of that dehiscence with a small surgical clip still visible in place. And then this is what necrosis would look like. So this is a right mainstem that's just full of necrotic tissue with a surgical clip. And then unfortunately, this is not something that's going to respond to just dilation alone. So that is an arrow stent that you can see in that patient's airway. Our stent outcomes. So if we look at uncovered SIMs that were placed in 25 patients at 27 anastomoses, sure, we can stent them. And patients will typically do pretty well immediately post-procedure. But it's not going to have a significant impact on their FEV1. And it's also going to come with a lot of complications. So they're going to have granulation tissue. They're going to potentially have lower respiratory tract infections. And those stents can migrate, requiring removal or replacement. The balloon expandable stents. So one of those is the ICAST or the atrium stent. This is nice because it expands uniformly. It goes obviously right through the bronchoscope and into place. It has a 6 French and a 7 French introducer sheath. This is approved for benign disease. So this is FDA approved for tracheobronchial strictures and comes in an assortment of sizes. It's easy to put in. It's a one-step balloon. You can flare these and they're ultra thin. So I can use these for segments and subsegments, but they are expensive and they also can migrate. And this is what this would look like. So this is a patient who had really significant ischemia reperfusion injury with necrosis and essentially lost all of their left-sided airways. So you can see these staggered ICAST stents. So in the photo on the top left, the lingula is completely obstructed, able to dilate that. And then this patient now has stents in their left upper lobe, division bronchus, their lingula, and their true left upper lobe. Requires a lot of airway clearance. If you put this many stents in the and again, this is a study out of the Penn group, and they looked at interventions in distal airway stenosis. Not a lot of patients, 5 of them, and unfortunately, it doesn't really change patient outcomes. So there's no real difference in the lung function at 1 year, how frequently they're getting bronched, and airway patency. So oftentimes it's a balancing act of, is it worth the stent, or is this somebody who can get away with frequent dilations? I had a case that I did this morning where a patient has diffuse bronchial stenosis after his transplant, and he just comes for frequent dilations. It's an understanding that the risk benefit of monthly bronchs versus the risk of stent is going to favor doing a monthly bronch. Silicone stents, again, for stenosis or malacia. These are easy to remove. They don't embed in the airway. They're also cheaper, and they come in a lot of different shapes. But they have to go in with the rigid bronchoscope, and they don't have the same flexibility as the metal stents. They also can obstruct with mucus, and they can migrate. These are the stent that we would often use, like you see here, in malacia. So somebody has bronchomalacia at their anastomosis. That patient might not be able to clear secretion. They could have frequent pneumonias. They might have that seal-barky cough and be shorter breath with exertion. Oftentimes, I will try to CPAP these patients first before I reach to a stent. Sort of that last resort, because we've been in this patient's chest at least once already for the transplant, and potentially prior to that, if they've ever had a biopsy for ILD, the last resort would be surgery. And again, these come in an assortment of sizes: tracheal stents, Y stents, carinal stents, and bronchial stents. Silicone stents, unfortunately, don't perform that much better than our metal stents. So this is 23 anastomotic stenoses. They were able to put stents in pretty much all the patients successfully, saw some improvement in the FEV1, but there was not really any difference in survival at 1, 2, or 5 years. And those stents, once again, came at the trade-off of complications like granulation tissue, plugging, and migration. And then T-tubes are something that we less frequently use in the transplant space, but if patients have had a tracheostomy and they have complications from that, or they were a heart-lung transplant with a tracheal anastomosis, a T-tube may be something that we are considering. It could be a bridge to reconstructive surgery or a definitive therapy for our non-surgical patients. It obviously requires a pre-existent tracheal stoma. So this is somebody who already has a tracheostomy in place. And then for the first placement, may require rigid bronchoscopy for guidance. And this is a case of a post-tracheostomy subglottic stenosis, where you can see a complete obstruction in the top left, and then a Montgomery T-tube in place after we were able to recapture that airway with the T-tube in place on the bottom right. again, as I mentioned, all of our therapies have potential complications. Anytime we dilate, we're obviously not aiming to overstretch the airway because of a risk of mucosal injury, cautery. Obviously, we want to make sure that we're only treating the airway. There is a risk of perforation. And then again, our stents are fraught with complications. Something that was brought up because it makes sense is that could we have these patients undergo hyperbaric oxygen therapy? It's an established treatment for tissue ischemia. So would it work in the transplant space to potentially attenuate bronchial injury? So the folks at Duke actually did the study. They looked at our usual care versus hyperbaric oxygen therapy in patients who had severe necrosis at week 4. And they had planned to do 2 atmospheres for 2 hours for 20 sessions. Unfortunately, their interim analysis showed no difference in the 2 groups. And so they actually stopped the trial early, only recruiting 10 patients in each arm. And with that, I will open to any questions.
Thank you, Dr. Frye. That was great. Really excellent talk. I think we all learned a lot. A couple of questions that we saw. You mentioned how we use uncovered metallic stents in the case of dehiscence, and you would generally remove those stents. What about these covered metallic stents you're putting in for stenoses? Do you have, are they lifelong stents? Are they something you're going and taking out? What is your general time process?
So in the transplant space, your stents should never be a lifelong stent. So I have unfortunately had to take care of a couple of patients where somebody had placed an arrow stent, for example, and then walked away. And then that stent is now fractured, embedded in the airway, and has significant granulation tissue. And you can imagine that the risk of trying to pull these stents out, as we know, those of us who've tried to remove these metal stents, it's like a bird's nest in the patient's airway when you try to remove them. So anytime I put in a covered stent or an uncovered stent for dehiscence, but really the covered stent. So let's say I have a BI stenosis and I just can't get a silicone stent to seat there. So I put in an Aero Mini. That patient is going to know that they are married to me until that stent comes out. And I'm going to take a look typically every 3 months initially, and I'm swapping that stent out. So sometimes I may not be able to remove the stent, but I'm at least taking it out every 3 to 6 months, just so I don't get a lot of biofilm and infectious complications of the stent. But I'm never leaving the stent and walking away.
Do you ever give them a stent holiday to see if they restenose? So, what is your general technique there?
I will try. I will say I've been very, very unsuccessful with malacia. So unfortunately, I don't feel like the airways and transplant patients remodel enough to really liberate a patient with malacia from a stent. I actually looked at all of the patients that we stented over a few years at Penn, and 23 out of 23 still had stents for their malacia. Just it doesn't heal. Stenosis, I think, is more favorable. So oftentimes, I don't typically pull them out at like 4 to 6 weeks, but usually I'll try to pull them out 3 to 6 months. And then if things look good, I'm going to leave it out. But it's not a patient that I'm going to pull a stent out and be like, okay, go home 4 hours away. I'm going to have them stay in the area because I want to know if they have issues.
Definitely, definitely. I think those are all the questions we had today. And once again, I really want to thank you for your time and an excellent talk. And I know that I personally learned a lot, and I'm sure the rest of the group did as well. Thanks
Awesome.
again.
Thank you.
Thank you everyone for joining tonight's webinar. And yes, once again, thank you, Dr. Frye, for this very informative talk. We look forward to having more webinars in August. Thank you, everyone. Have a fabulous night.
Thank you.